All right. Hello and welcome back to the show. What's best? I love it. I've said this for like the last 30 and swear I only say it when I need to. My guest today really exemplifies what's best for the patient is best for business, right? And I say it a lot, but man, there's like this core group of people just got back from speaking in Alabama on patient engagement. And of course, Katie Obright's name had to come up. Because when I talk about looking at the bigger picture and doing what's best for the people we serve and having to start to take a bigger look, then your name has to come up. You were on the show. We're just going to state a year and a half, 2 years ago to talk about the same thing. But man, a lot has happened. And that's why I reached out to you and said, it's time to get you back on and let's update all this stuff. So I'm going to let you introduce yourself, Katie, share your journey, talk about where you are today and what's going forward, because I believe you're a huge solution that physical therapists need with
Oh, well, thanks.
no
Thanks.
further ado. Yeah.
Yeah, thanks so much for having me on the show. And I don't think I'm the solution. I think I'm just I think I just am loud and I
Well, what a
yes.
coincidence we're on this show together,
Some people
Katie.
can relate to that. Um I think so I'll just introduce myself for those
Yeah.
that don't know me. My name is Katie Obright. I am the proud owner of Redefine Health Education.
Look it up.
And this is I'm going into my 5th year in business. And at Redefine Health Education, my primary mission and primary goal is to help physical therapists get into integrated primary care spaces. And we do that through education, mentorship, and advocacy. And that is education, mentorship, and advocacy to the physical therapists, to business leaders, to other health professions and health professionals, business administrators, and also the public. So that's kind of a big role. And there has been a massive movement in the year of 2025, which has kind of paved the path of what we should be expecting going forward. And thank God it happened
Yeah,
because
right?
go ahead.
Right? No, I'm just agreeing with you. Thank God it happened. There's all these tipping points recently, right? And it's more than one, but man, thank God, finally.
Yes, thank God
We knew it had to
because
get worse before it could get better. It always has to. And I'm sorry, but it does, man.
yeah, and I have felt that, and unfortunately, my business and this mission has evolved to kind of accommodate to that. Um, but this year we finally saw the ABPTS primary care clinical specialization pass the House of Delegates. And again, for listeners that don't understand what this is, ABPTS is the governing body for the physical therapy board specialist certifications. So, for example, I have an OCS. I'm an orthopedic certified specialist. Some people are neuro certified specialists. Well, now we actually have a clinical track for primary care physical therapists to become board certified specialists, which is huge in so many ways beyond what it is for other specialties. And I'm biased, but let me paint a picture.
I believe you, by the way.
Yeah. So the picture looks like this. The last clinical specialty to come into the sphere of specialties was oncology. And again, thank God for that. We need oncology clinical specialties or clinical specialists. However, um, there still has been no real movement or no real catalyst to reposition physical therapists in general as care professionals that are able to provide a direct entry primary care management service. And none of the other clinical specialties truly meet that description. But now, with this primary care clinical specialty, not only do we have a way for individuals who want to practice in general practice settings, which is truly what I probably have always wanted to do. I ended up as an OCS as a result of probably my time in the military and other things. But after that, I really truly saw myself as more of a primary care generalist specialist. And I think that this trajectory for our profession is going to allow us to have the opportunity to advocate for our profession moving into the primary care provider roles and for CMS, Center for Medicare and Medicaid Services, to actually recognize us as such. And I don't think that we've had that type of avenue or direction anywhere even close prior to this. So that's kind of like maybe the first thing we can talk about.
Well, that's an awesome intro. I think here, I want to highlight some stuff I heard you say, right? Came from the military background, of which I love hearing military trained physical therapists speak because it's just a mind, my mind gets blown every time. I heard Drew Contreras sharing about how him and one person would travel and the number of people they treat in a day, and right, and the impact they'd make, right? So I love hearing that, and which is truly a primary care PT in that model, correct, Katie?
Right. So actually my very first job straight out of PT school, I was one of the weird ones. I graduated from Temple and then went straight on active duty. I had a service obligation connected to my undergraduate ROTC experience.
That's
And
cool.
my very first job, my first boss was like, "All right, well, you can be here for a couple of months, but then you're going to primary care." And I was like, "Oh,
Oh,
okay."
wow.
So I just kind of baptism by fire. I
Yeah.
didn't even know that that was a possibility.
Yeah, right.
And he said, "Hey, you're gonna go and be the embedded physical therapist in this primary care clinic in a soldier-centered medical home."
Where I
Um,
assume a
mhm.
lot of MSK roams through.
Oh, yeah.
Might I be right, Katie?
Yeah, and there's like a famous picture that kind of circulates. I don't know who it belongs to. I actually think it belongs to Don Goss, who is a retired Army PT colonel, and I think he's faculty at High Point University now, unless he's left. I don't know. But there was this awesome picture of his time when he was at West Point, and there was a sick call line. So sick call is kind of like whenever anybody is sick or has an injury and they can't go to morning PT, which is physical training,
Oh,
not
yeah.
physical therapy, but
Yeah,
whenever
right.
they can't show up for PT, they have to show up at sick call. And there's one line for people that are like ill,
Oh, yeah, yeah, yeah.
quote sick, like have the flu or whatever.
Mhm.
And it's this tiny little line, maybe 10 people deep. And then there's the line for people with MSK stuff. And it's like, all the way back, like wrapped around. But that truly is what it is in that
That's what I
particular
thought. Yeah,
population.
that's what I thought. So the military background, so the primary, but which means right going into that primary setting and the baptism by fire. Here's something else I want to speak to that you said real quick, because I've been in this, as we discussed before we turned the recording on, been on this journey for about 34 years now. So I've seen, right, our profession early on. I have my MPT. I saw the, I saw the DPT show up. Um, then I saw the certification show up. And during my journey in this, and let me just say this because it was early on, right? It was small. There were small sample sizes, everything. I was having a hard time seeing the value. Don't mind you, I leverage the DPTs and if you have the certifications and the DPTs, in my role now of selling an expert, I leverage them like nobody does. So understanding what the public wants, you start to get a different vibe. But I got to see that all unfold, and I wasn't quite sure of the value. And I think of all the certifications, and people used to show up for interviews, and I'm like, I'm sorry, I get it, but I can't give you more money for that. I really didn't see how it translated. But my God, Katie, if I started a clinic tomorrow and you rolled in with a primary care PT certification, I'm going to tell you, you'd probably be the first hired, and I'd probably hire you on a higher level to now start building out my primary care. I'm going to call it, silo's not good, vertical. And
Program, yeah.
so I just wanted to throw that in there because as you were going through that, I was like going through all my journey and going, oh my God, but if you showed up today with a primary care, holy shit. And I'd probably give you more than you asked, and I'd put you in charge of it.
Hmm. Yeah, I truly see the specialist certification as a vehicle.
Right.
Now, are there physical therapists out there and current, clinical specialists with other systems-based specialties like neuro, orthopeds, whatever?
Yes.
Are there specialists out there that certainly could already meet this role?
Yeah.
Absolutely.
Yeah. Right.
However,
Right. We know that.
what does that mean? What can we use those as case examples of individuals that would be able to handle anything that walked through the door. Or so the way that I paint this picture, and truly in graphic form, is the scope of practice of a primary care PT is 3 feet deep and 3 miles wide, whereas the scope of practice of a more narrowly focused, a secondary physical therapist is really kind of 1 foot wide and 10 miles
Yeah,
deep.
and 10 miles deep, right? Yeah.
Right. And so we kind of talk about this, or draw the distinction of that in our primary care PT consensus definition paper, which, fingers crossed, will be coming out in PTJ within the next few months, unless they reject our revisions. I don't know. We'll see. But we spent time, and by we, I mean the primary care special interest group board members. We spent time developing this consensus definition, and then it went through several rounds of public comment and revision. And now we finally, hopefully, will be having this consensus definition released, so that was like kind of number 2 of this year. Big things to be coming out.
My journey's been 34 years. I'm just thinking about where we're finally getting to and talk about things how to get worse before they get better. And by worse, I mean, I when I give a talk these days, I lead with a slide that shows that it actually costs you more to die earlier in America than when I got out of school. So, right? So it costs you more money to die earlier. So I'm like, and then you could roll out the low back pain numbers. So I'm like, someone help me out. What did I do to the fucking what? Right. Right. And my goal is to leave things better, and I found it. So I'm trying hard, but I got no proof. Right. So I've been on this journey, but I remember at some point in this journey, a long time, probably before you were out of PT school, Katie, where I was like, why isn't there a PT in all these primary care offices? And it
Right.
wasn't to do primary care. It was to be there to help them offload the workers' comp. I'm sorry. That's not what I meant. The musculoskeletal. And it was weird. And these were I tried to do a research study as a student over 34 years ago on like programs in the Safeway. I grew up where Safeway was huge. Why are we sitting around waiting for people to get injured? So I was always wondering about upstream, because to me, both of those are upstream. And I say
Mhm.
that word a lot, right? So it's so interesting to see all this stuff finally coming together. And people are going to have to start. I love your definition, the breadth versus depth. That is a brilliant, that visual to me. As soon as you said it, I knew where you were going, because I'm like, you're so right. People need to hear that and understand the context of November 2025, because what got us here ain't getting us there. Okay.
Mhm.
It ain't getting us any further. And that was the thing we were talking. So I'm fresh off of PPS, and I was debriefing a little bit with Katie, and I'm starting to feel, so it's November 2025, whenever you listen to this, and this is not a PPS recap, but I'm feeling that the conversation now is leading with, okay, I get this stuff. What do we have to do differently? And it's like, sweet. And primary care has to be one of them, direct to employer. I was confused. So maybe you can help break that up for us, right? Direct to employer versus primary care. Well, why don't we do that? Because I believe both of those are where we need to go in the future. So break those up
Yeah,
for us, Katie.
I think that is a great place to start, because I think that people do get confused about some of the definitions,
I do.
and we actually account for all of that within the consensus definition paper.
Cool.
So that's going to be a really great resource when it comes out. Again, hopefully another couple of months in PTJ, maybe we'll see. Um, but what we talk about is, and actually what I know I can mention is what the definition actually is, because it was specifically voted on, and that part is not changing. So the definition of primary care PT, we start out this whole paper talking about the greater context of primary care. General, what is primary care? What does that term even mean? How is it defined as it relates to the role in the health system, the healthcare system organization?
This is going to be a great
primary care
paper.
versus secondary versus tertiary versus emergency. It's all different things. What does it mean as it relates to provider types and teams? And what does it mean as it relates to attributes and services? So we frame up the paper this way. And then from there and from all of our research there, we extrapolated, well, okay, this is what it means to be a primary care physical therapist. And so the definition of primary care PT is a professional practice area in which physical therapists provide first contact and ongoing. Okay, so there's three kind of key terms here. First contact, ongoing, broad spectrum, preventive and reactive health management services as an integral member of the primary healthcare team. Physical therapist's primary area of expertise is to address pain, disability, function, health, and wellness in order to optimize participation in life activities. The care is person-centered, team-based, and community-aligned with the goal of achieving improved health with higher quality of care at lower costs. So it's like there's a lot going on there. Are you speechless?
I mute myself every once in a while so I don't talk of you. I'm going to state as someone who's been around a long time, the longer you've been around, the more that makes sense. It really does. And this idea of, right, we've got to re-examine and recheck, of which this statement makes us do, where our value is to the system as a whole.
Mm-hmm.
And I
Yes.
don't mean HOLE, I mean WHOLE, right?
Correct.
And this will make us, it has to. And God bless the new kids coming in, and I'm going to say kids, and I don't care if the students are older than me, they're still kids. God bless the new kids coming in. If they get a hold of this and have access to this and hear about this, it's then the change will happen. I'm not leading the change. I'm just trying to yell it louder. Because we need people now executing. So,
But
is
back,
that?
I do want to address though the primary care versus direct to
Oh,
employer
sorry.
and
Yeah, because I love that definition so much. I can't
yes.
wait. Right? I love it.
It's a good definition. It
Sorry.
went through multiple rounds of revision with a lot of really important insight and input. And so what we also talk about in this paper is the settings and populations. And then we also talk about the payment models. So they're all kind of different things. We have this definition, which kind of sets a framework for how the primary care PT ought to practice or be incorporated into an existing system. But then all of these other features are kind of variable. And that's a good thing because we can position primary care PTs in a variety of different settings. So some of the settings that we specifically talk about, including but not limited to primary care clinics, physical therapy clinics, work sites. So, you're on site in a factory or in an office setting, community centers, sports teams and sporting facilities, wellness centers, schools, and homes. So it's pretty comprehensive. But the thing that's different about what a primary care PT is doing compared to, your typical outpatient PT is entirely like the mindset and the management and surveillance. The management and surveillance factor is pretty, it's entirely different. Your role as a primary care PT is to assess and stratify that patient's risk based on all sorts of different factors, both individual risk factors that are intrinsic or extrinsic, as well as population health risk factors. So for example, where that patient lives, what kind of food they have access to, what their income level is. All of these things are going to contribute to their overall health risk. And some people might say, well, why does that matter for a physical therapist? Isn't their physician doing it? Well, we all know that in 2025, we're in a world where patients spend less and less time with their primary care providers if they have one at all. So, for us to be incorporating these risk factors is extremely important, and it's something that the traditional outpatient physical therapist is not doing a very good job of.
Yes.
So then kind of moving on to just talk about different payment models. The direct to employer, well, let's talk about payment models. So there are a variety of different ways that physical therapists can get paid as working as primary care PTs, and one of the fundamental ones is fee for service. That's what we're doing in a lot of other settings. So certainly you still can bill fee for service as a primary care PT, whether you're integrated in a primary care team or not. There are some considerations, of course, when you are changing settings or in locations of care. However, it certainly can be done. And we actually recommend not billing incident to the physician if you are in a co-located practice. There's a variety of reasons for that I will discuss in an upcoming primary care PT startup workshop that I have, and I'll talk about that in a second. But other payment models include the direct to employer payment model. So that is when you basically go direct to an employer, you figure out what their risk factors are, and you say, "Hey, I'm here to help you prevent your healthcare costs from going up by doing X, Y, and Z." And you're there on site, and then the employer pays you in whatever arrangement you come up with, whether that's they just pay you a salary, they do something that's kind of a per member per month type of arrangement, or other types of, contractual things. I don't know. There's a lot of different ways to do that. And then, of course, there's direct to consumer, which is, for those that don't know or are not familiar, take a look at direct primary care. There are physicians who are, charging affordable monthly fees to simply be your primary care provider. You have unlimited access to me for like $100 a month. That's it. No insurance, no nothing. I had my own direct primary care physician when I lived in Pittsburgh, and she helped me through so many crazy things that my body was going through at the time that nobody else could figure out because they weren't spending the time. So I highly recommend that. And I also think that PTs can function in a very similar membership style payment model. So that's that on payment. What do you have to say, Jerry? A lot of things, maybe.
Does Yeah, I don't want to get into billing. I just, we're going to leave it like that, and I'm going to recommend people attend your. Yeah, I don't want to do this because it's not the right. This isn't the conversation now. And of course, everybody wants to know will you get paid, and then we get lost in the weeds of the true value of this. So I'm not even going to bring it
Right.
up. I was just going to make you break it down. But if you do it in the startup thing, then that's where people need to be, and they'll get all their questions answered. Forget it. Yeah, no,
Yeah.
I love the fact you just presented all those options to us. So again, let me stick with the positive side of this. I was just going to ask for clarification on one thing, but I love the fact you lay out all the ways you can get paid. Yeah, this is good, man. This is what I wanted. I wanted the update. So so you said you're doing a primary care startup workshop. What are you doing?
Yeah. So in 2026, and actually I just finalized the date today. I am doing, and this has been highly requested of me for several years now, and I'm finally just kind of
I
getting
bet.
my
I
getting my
bet it
bag
was.
here.
Yeah.
Um, it's a primary care PT startup workshop for business leaders. It is designed for people that have the authority to make changes in their operations and the operations of their business in order to implement and integrate the concepts of primary care PT into what they already have. And so it's going to be a hybrid format. There will be approximately a 4-hour online pre-work course. And, you'll watch videos, you'll kind of participate in some reflections and things like that. And then there will be a 1-day live Zoom workshop where we will hear from a variety of different experts and individuals who are actually working in these spaces. And it'll give everybody there an opportunity to kind of get their questions answered so that they can figure out how it can apply and how it can work with them in their organization. And we're going to be covering everything. I'm intentionally excluding military and VA because their systems just don't apply to the rest of the world. And I'm saying this as somebody who was in the military and practiced there, and also somebody who's very familiar with the VA system. I'm intentionally excluding those two settings because I really want to focus on because they already have it. They
Yeah,
already have
right.
primary
So,
care
yeah,
people.
got to get it out of there. Yeah, well, get it out of there. You know what I mean?
Right. We need to focus on how we can bring this model into mainstream American healthcare without without there being this like, oh well, you did in the VA, that doesn't make sense for us. So we're going to be hearing from individuals who are um, in large health systems, and they have physical therapists that are working in co-located primary care settings, accepting warm handoffs for musculoskeletal or vestibular conditions or issues related to balance. We're also going to be hearing from individuals who are familiar with accountable care organizations and more value based care arrangements. We'll also be hearing from individuals in private practice who are incorporating this model in walk-in clinic formats where they almost provide or they do provide musculoskeletal urgent care within their practices, so walk-in clinics, but also just how people are making this work where they have some same day or acute slots, but they're working with physicians in their community to make sure that those acute slots actually get filled by the right patient at the right time. So we're going to be hearing from a variety of different people. I'll also have a payment expert, so somebody who's very well versed in the insurance space who can answer questions for people.
See,
Um,
there you go. I told you that'd get answered if they show up.
exactly,
I
yeah.
didn't
So
even
that's
have
going to
to
be a
ask
big
it. They'll get
part.
the answer. Yeah, there you go.
That's going to be a big part. And then we're also going to be hearing from individuals who are preparing these types of practices in underserved communities, and just some of the different barriers that are associated with federally qualified health centers, FQHCs. There's just some different things to consider there. So this will be awesome. It'll be up on my website, available for registration by December. By the time, so it's November 18th today. So by December 1st, the registration will be open.
Oh,
The
this will
online
go out right
pre-work.
around there. This is
Will,
going to go out right around there.
oh,
So
perfect.
it should coincide. This would be good.
Great.
And
The
that link will
online
be in the show notes, by the way, people.
Good. The online pre-work will be available January 1st, and then the live Zoom will be May 20th in 2026.
Can I reflect on a couple things
Yes.
One is people need to understand you don't have to blow up your whole business and start over. So
Mm-hmm.
I need to say that out loud because I have these conversations with people and all of a sudden I see the look in their eye and I'm like, I'm not telling you to start over, right? And you use multiple examples. I'm not even going to bring them up. Like the acute slots here, I'll bring up one. Yet you don't have to blow up your current model and, right? Fee for service and the need for that level, I call it tertiary care, by the way, for that level, that where you sit around and wait for an injured person to call you, right? It's
Mm-hmm.
tertiary care. That will always be there. It just can't be the focus of the business. So if you have a primary care portion, if you have, I'm just going to say direct to employer contracts separate of the primary care side, and you have the fee for service, I'm like, I'm going to say you're going to survive when a lot of other people wouldn't. I'm also going to challenge the newer people, the younger people. I shouldn't say younger, the newer people to the profession that if you're if you're looking to get paid what you think you're worth, then you got to go this route. That's the other thing, right? I've talked to people multiple times about the opportunity on the other side of this stuff. And it is far bigger than sitting in a clinic treating 10, 15, 20 people a day. It is what it is. And so all these complaints I listen to, and again, it's complaints meaning, hey, where is this opportunity for me? It's over at Redefine Health Education or Redefine Health.
Redefine Health Education. So
Thank you.
Redefine Health actually is a healthcare system in New Jersey.
Oh,
So Redefine
awesome.
Health Ed is good.
Okay. Right. And the solutions are there. And this is why I started with the way I did before we hit recording, that people are starting to ask for these solutions. Right. And so I'm here to tell you, and this is awesome timing. I'm not going to call this a PPS recap, but I'm going to go, if you were at PPS, then you want to listen to this because people are asking for solutions. And it was like,
Mhm.
here you go. So what's the next big, so if and I don't understand because I haven't been in that world. is there anything writing on the paper getting accepted by the PTJ, or is it already good to go on paper and you're just waiting for it to get published?
We submitted revisions for anybody who has experienced peer-reviewed review processes. It can take some time. So
Yeah.
there could be another round of revisions. We just don't know. It might, but these things take time, and it takes time for a lot of the editors are volunteers, so it can take time for them to review it as well.
Yet what is, just bear with me on this because I don't know the process.
Mhm.
So this is basically, once it gets accepted, then you guys get to more validity. What happens because it got accepted? Does it
Uh,
just go out and prosper so everybody knows what you're doing, which is valuable stuff?
Correct. So
Okay. Just want to make sure.
yeah, so it actually currently is available, the original version, which
Okay.
I actually think our revised version is a much better, which is a really positive thing about the peer review process. The original version is published as a white paper on the PCSIG website,
Okay.
aptafederal.org. So it's
Okay.
already there. People can look at it. But when we go through the peer review process, it truly does, most of the time when it works right, it makes the papers better.
Yeah,
And
cool.
it makes it so that it answers more questions about, things that you thought that you addressed, but you didn't.
But people are
So,
going, this doesn't make sense, and you're so deep in it, right? It makes sense to
right.
you.
And that you don't even know that you're like missing a
Cool.
fundamental piece that needs to be addressed. So we submitted revisions, and then once it is accepted, we can release an unpublished accepted manuscript.
Cool.
And I intend on doing that like the first minute that it is
Cool.
published, so that people truly understand what the difference is in the role of a
It's
primary
huge.
care
Yeah.
physical therapist compared to just a general traditional rehab PT.
Follow up to that. Are there any other barriers in front of you right now, or is it just getting people to engage and understand what it is and see the value in it from the professional side, let's say, from the PT side, physical therapist side?
Yeah, from the PT side, there are a lot of barriers, and one of the things that keeps coming up is, believe it or not, Jerry, you and I are a little bit different. Um, there are people that attend these conferences and that do all of these things to try to advance the profession. And then there's about the 80% of the profession that doesn't really contribute to that, and they're not really interested in doing things any differently. And one of the major barriers with this model is it's truly not for all PTs. It's really not. I
100%.
used to think that way, but it's not. And I've had students in my classes before, because I actually teach post-professional education. It's all my courses are on redefinehealthed.com if you want to see them. But I teach fundamental concepts in primary care PT.
Right.
And I have had students challenge me on, oh, that's not something that we should be doing.
Yeah.
That's a referral back to primary care, or, let them just handle everything. And it's like, no, we need to be more actively involved in this. So there is a barrier with the PT community itself. And I don't know. I'm not sure how to feel about that, other than just knowing that this model and this type of work just really isn't for every PT, which is fine. We still need PTs
All
in
settings, right? I mean,
yes.
that's kind of the beauty of the profession. As people sometimes say, well, it's hard to represent us in certain places, but in other ways, it's an advantage, right? That we can
Right.
serve across so many uh, needs. I,
Right.
I
Um
just, man, you gotta look at the system as a whole, my friends, and a lot of this stuff starts to make way better sense. And where, by the way, I've said this a gazillion times in the last 3 years, where your value truly lies in the system, I'm going to challenge you, is not where you're sitting today.
mhm. Another big barrier in the PT profession, it's not a total barrier. It's just a barrier that presents, we have some workarounds for these things, but we certainly need a little bit more advocacy work needs to be done about our, CMS does not recognize physical therapists as primary care providers. So even though in Utah now by regulation, um, recognizes physical therapists as primary care providers for neuromusculoskeletal conditions, CMS still does not. And so if CMS does not, there's a precedent to be set there that PT is its own therapy benefit. And so from a payment perspective, until we are recognized as primary neuromusculoskeletal providers, that that payment barrier may not change. Now, I think there's some hope for that because, like, let's look at the system in the UK just as an example. In the UK, in the NHS, the National Health System, they have physiotherapists, and then they have advanced practice physiotherapists, or they call them FCPs, first contact physiotherapists. And those physiotherapists actually do have advanced training in certain areas, medical screening, diagnostic imaging, injections, lab tests, and lab studies. And they are allowed to practice at a higher level because of that distinction and recognition. So it is very possible. I don't know if this is ever going to happen, but it is possible, or it's plausible, I should say, that the primary care clinical specialization, that board certification, could serve as a distinction to get PTs
That's what
recognized
I
as
thought of
primary
when,
care
yeah,
providers.
that's what I was thinking of when you first shared it as one of the things, right?
Right. Right. So that is quite possible that could pose a pathway for us so that we don't have to be so stinking restricted under this therapy benefit where every patient that we see, in order for them to pay a bill, we have to show that they have a functional impairment, something related to gait or this or that. And technically, under the PT therapy benefit, under the rules, it would be like out of our scope of practice
Right.
to see somebody for cardiac rehab, because that's
Right.
kind of part of a separate benefit,
Right. Right.
which
Right.
is
Right.
insane because that is well within our scope of practice.
By the way, I did that forever ago. I was
Yeah.
taking people through cardiac rehab when I was working acute care.
Yeah. And so I definitely think there are barriers, there are things that need to be done, but none of them are absolute barriers that would pose some kind of hindrance to you starting a primary care PT
Right.
program like today, right now.
Right. Right. And this is one of these things. I'm getting a little older, so I don't like to be behind on things anymore. Right. Yet I'm going to challenge those who are younger to the profession. So meaning they've been in it a shorter amount of time than me, that don't wait to see what others are doing. Listen to people like Katie, broaden your scope and talk to people, because the ROI on what you do today is far greater tomorrow than if you sit and wait and see what everybody else is doing. The people that get out in front of this are really going to be, by the way, they're going to be making some of the rules. They're going to be driving some of the rules. And when I was in practice, when it came to direct access and stuff like that, I was willing to skirt the gray. Someone was like, well, PT in California just needs to get sued and we can prove this. And I'm like, I'm all for it. Nothing ever happened, but just, how we defined diagnosis and things like that.
Mm-hmm.
So get out in front of this. And we're so fortunate to have someone like you, Katie, leading the charge. And I see your stuff out there. And that's why I was like, Katie, is it time to get you back on the podcast? Because I see all this great stuff flowing out of LinkedIn. Where else are you besides LinkedIn?
Just LinkedIn and Instagram. And truth be told, I am not amazing at maintaining a consistent social media presence. Something that I'm working on. But I am very, very active. I do look at everything, but sometimes I'm not a consistent poster. I'm trying to get better.
I've seen some, I feel like I've been pretty updated, right? I can put the journey together and if you're going to say few posts or whatever.
Yeah. I
So
also
then
have a
we had
podcast.
the podcast, what Redefine Health.
So actually it's easy. It's the Primary Care PT podcast.
There we go.
And on that podcast, there's a ton of really great resources. Not only just interviews with other people that are practicing in primary care, but also I have just some different clinical cases. I've interviewed physicians who have been a part of these models before, and
I see those pop up on LinkedIn. You're sharing the right stuff, man.
Yeah. Well, maybe I'm doing better than I think.
Yeah. But yeah, all of a sudden I realized, wait a minute, I know your podcast from LinkedIn and I see you interviewing physicians, and that's what always gets my attention. It's like, who's interviewing physicians? Oh my God, a PT, right?
Well, and here's another thing that I should say. There's actually been, I've been made aware of two different health systems where physicians were the ones who were reaching out to PTs trying to get them into their clinics. It's been a physician-led initiative. And so if you're somebody out there who's saying like, "Oh, I don't want to be a bother to physician practice or whatever," don't stop thinking that way. That's a really antiquated and, old school way of thinking that like physicians somehow don't want to work with us. Maybe they don't want to work with us for a lot of other reasons, but it's not just because we're inferior to them. That has not really come up in my experience. It has not. So, a lot of it just has to do with they have such a busy working environment and there's so many strains that like changing or doing anything different seems like a challenge. But they need to be actively involved. And I do believe there's a lot of them out there who would really like to work with us.
That's cool. And you're talking, and just bear with me, primary care MDs. You're talking about primary care practices right now?
That was primary care, but the one setting where it was actually orthopedic surgeons that
I
reached
think I
out to the
saw that
PT
story.
department
I think
there.
I saw, if you saw something and heard it, I think I might have saw at least one of those stories.
Yeah, so it is not just primary care. I do think that team-based care is becoming a lot more commonplace and a lot more sought after. Orthopedics, OBGYN, Urogyn, um, and oncology for sure. So there are different specialty practices where PTs can and should be integrated. Pediatrics is a great example. Ryan Jacobson is
Oh
just
my
totally
God, I
leading
can't
the charge
imagine,
there.
right? Not having a freaking team for pediatrics, right?
Yes. Yeah.
Real quick, I want to throw another 2 cents in there. It's interesting because I don't want to go down this path, but I'm going to say this word, this value-based care, because what it's, so I probably started this process of understanding primary care, direct employer after going, okay, what's this value-based care thing? And then going deeper into there. What's really interesting, this is my take. I think it's been proven, but it's still my take is, you're going to have to get on a team to get the biggest. I'm going to say it again. I will talk about the money part. To get the biggest bang for your buck, it means you're impacting people. No, it means you're impacting the system and people are part of the system higher upstream, and you will be able to reap the benefits of preventing things finally and keeping people out of situations rather than waiting for them to get in a situation. And because of that, it will take a team approach. And actually, it's not 5 people collecting the same $75 you got for a PT visit. It's 5 people collecting a lot more money than that and being able to split it up. So I'm just going to say it like that. And you deserve it because you went upstream and you kept people out of a shitty system. And now the system has the money to give back to you because they're not in it. So I'm just going to leave it like that.
Absolutely. And I
And that's
also
one way, by the way. I know that's not the only way, but that is that
right.
team approach, right? It's a bigger piece. It's always, I'll never forget the one day someone drew me a picture of a small circle and said, do you want 100% of this pie or do this huge pie and chunked out like 25%? Or do you want 25% of this pie? That's what we're talking about right now. We're fighting over that tiny, tiny pie when that big one's sitting there, and we don't need to own it all. We just need to own where our role is and all that. Would you agree?
I would absolutely agree. And one of the things I would say on that piece is especially for your listeners, and I think that you're kind of mostly in the private practice space. And for your listeners, one thing that would be
My
that
mom
can be
listens.
super, super impactful is if um sorry, excuse me. You need to close the door and just go back downstairs
Awesome. Katie told me they were
just
coming
for
up.
a moment, just for like 10 minutes. Okay.
Max,
My
Max.
children just got home
No,
from
it's all
school.
good. Max. No, no, no. That was perfect. I love it.
One thing that, one thing you talked about was you don't have to blow up your existing business model.
yeah,
You absolutely don't.
good.
But there in this startup workshop that I'm going to be putting out, one of the people that is going to be talking, they are part of a private practice, but they have trained themselves to speak the language of the primary care providers that are within these ACOs that are under a value-based arrangement. they don't have a physical therapist on staff within the primary care clinic that functions under value-based, but anytime they refer out for care, that care gets deducted against, their payments that they will get back to the practice. And so if they work with a private practice PT that understands that and is willing to give the highest value service without stringing along their visits, just to get some like arbitrary length of stay metric, which is god awful, by the way. And I'm just going to lay it out there like it's the cancer to our profession. But they know that, and they've been able to generate a lot of business from this particular primary care service for that reason, because they have learned how to speak their language, and then they actually feel like they're really doing right by their patient. They're doing right by the whole healthcare system. They're containing cost. They're working collaboratively. It has been a really positive thing for their relationships with the patients and with these primary care physicians.
So, if you want to hear more real case studies and more real world examples and learn how to, as I say, learn how to join Katie in the future, that's the thing. Katie is not painting a picture of the future. She's in the future and she's telling us how to get there with her. Then go look up, tell me the name of the program again exactly.
It's the Primary Care PT Startup Workshop for business leaders, and it will be available on my website. Just go to redefinehealthed.com.
ED on the end of that, redefinehealthed.com.
Correct. Yep.
And look for the startup. I'm going to go take a peek at it too.
Yeah, I honestly think that this is going to be a really solid workshop for anybody in the profession who really just wants to learn more about, like, what is this? How is it different than what we currently do? And who's currently doing it? And how do we potentially
Well, I love you bringing the
this?
case studies and bringing up these different examples. And God forbid people leave there and go, oh, I never thought about it that way. God forbid that happen, including me. So, wait a minute. I didn't think about that. That can't be possible. This is awesome, Katie. This is the catch up we needed. And I didn't know what Katie was working on, but man, I love to give people the opportunity to talk about their great work they're doing and then pitch how they can help you. And I bring Katie on because I believe she has a lot of value. So I'm going to encourage you to go sign up for that damn course. And I don't get a penny of it. I think there's huge value to I always have to say that. There's huge value to you and the profession to go sign up for it. So I'm so glad I brought you on, and what perfect timing to get you on here. And we'll just pretend like you didn't plan it to pitch your thing. I know you didn't, because I know you did. I'm teasing
I mean,
you.
it really was just kind of perfect.
Well, I looked down, you go, and December 1st, I was like, what'd she just say? So this is great. By the time this rolls out, might be a little bit past, but man, everybody needs to get on there. And you'll probably see me sharing it on my social media. But remember, redefinehealthed.com. Dr. Katie Obright. You rock. Thank you so much for coming on. Thank you.
Thanks so much.